Madam, make a excuse. Can you see me? There is no one.
Good morning. Welcome to all combined super meeting with the Lanka Society of Nephrology. So, as rheumatologists, we are
Yes, good morning, all. Thank you very much for that kind words of introduction, Chairperson, sir, and Madam. First of all, I would like to thank the College of Rheumatologists as well as the Society of Nephrologists for initiating this type of CME program. And so, over the next 30 minutes and so, I'll be starting off with or discussing about. So, if you go to the topic, hope it's self-explanatory, where I will be talking about diagnosing SLE and sort of a controlling the bad part of it. So it's a catch a butterfly and tame a wolf from rheumatology perspective. So the first thing is word lupus. It's a Latin terminology where lupus comes from the word wolf. Why you call it a wolf is certain skin lesions in lupus resembles the bites of wolves. The second thing is, if you look at this, sorry, are all the mics muted? Right. So there's echo coming. So if you look at the fur pattern of a wolf, resembles a sort of a male rash in a lupus patient. So as you all know, systemic lupus is a multi-system autoimmune disorder characterized by diverse clinical manifestations, where there's a spectrum of clinical manifestations, starting from mild N to a more severe N. Mild spectrum contains mainly mucocutaneous manifestations such as oral ulcers and all these malar rashes and subacute cutaneous lupus, etc. Where the moderate disease entity consists of sinusitis or cardiopulmonary involvement, and more severe spectrum deals with lupus nephritis, CNS lupus, vasculitis, and thrombosis. When talking about the natural history of systemic lupus, there are triggering factors such as sunlight, is it something to do with the oh, this echo just see if I am needed. Hello. So you switch out. Yes, yes. Sorry for that interruption. So, natural history of systemic lupus. Generally, there are triggering factors associated with triggering of lupus. One thing is we all know sunlight or UV exposure, as well as infections and certain drugs can trigger up lupus in genetically susceptible patients or individuals. Where there's a preclinical phase where autoantibodies are seen, which are general as well as specific to lupus. Then, as the time goes on, the first inflammation starts off and the first organ involvement sets in, and subsequently, flares with other organ involvement leading to damage. And sometimes premature mortality. In addition, there are comorbidities associated, such as infections, atherosclerosis, and malignancies. So, whole of my talk today would be based on this particular graph. This is a study, a landmark study done by Ugarte and et al. In 2015, where it demonstrated that, as you can see, flares of lupus would lead to a sort of accumulation of chronic damage, leading to premature mortality or death. So, to counteract this phase, there are some important things that we should consider. We look into the diagnosis, then assessment of disease activities, management with the treat to target strategy, and also look into the assessment and minimizing chronic damage. So as I mentioned, this is the outline of my presentation. First of all, I will be talking about diagnosing lupus. So this is a typical medical student day history where we would expect in a lupus patient. 27-year-old female presenting with symmetrical inflammatory polyarthritis for 3 months, noted to have oral ulcers, increased hair loss, and a malar rash. There was a thrombocytopenia managed as ITP during her first pregnancy. UFR showed protein 3+, red cells, and she had a positive DNA and a DSDNA. So this is a sort of a what we call dream history for a medical student. But when it comes to, so this is the typical rash of lupus, where there's a sparing of nasolabial fluid with a malar distribution. This is a DLE rash and also the oral ulcers. So this study shows that key features and organ involvement SLE, but strikingly, I don't know, it's maybe the study population is skewed because this was taken from a EULA article, and maybe sampling is more onto the arthritis patients, where renal disease was nearly 21% and neurological manifestation was seen in 18%. But more of the symptoms were related to cutaneous manifestations and arthritis. But interestingly, if you look at these things, there is 31% had fever, and also in childhood SLE, fever is a common manifestation, and renal involvement is a common manifestation. So, but real life scenario won't be like this. What you would be getting is, as a clinician, this is a case I have seen in Birmingham when I was in foreign training. 40-year-old Afro-Caribbean female with photosensitivity and hair loss who had a strongly positive lupus serology with no other clinical features, reported on recurrent vomiting, which was initially labeled as psychological or malignant. Further investigations revealed a delayed gastric emptying with a possible autonomic neuropathy. So at this point, the clinicians were sort of nowhere whether to start on. She was obviously started on hydroxychloroquine, but did not escalate into another immunosuppressant treatment. That there was, since there was no solid evidence to say or report on other organ involvement. But subsequently, 1 year later, she developed a membranous nephropathy or class 5 nephropathy. Where she, yes. Then the second patient, this is a patient whom I have seen in 2015 when I was a registrar with Dr. in RRH. 23-year-old patient with fever, leukopenia, and thrombocytopenia, admitted to a medical unit, agitated on day 4. So obviously, if there's a thrombocytopenia and leukopenia, people would think about dengue, and the agitation was attributed to dengue encephalitis. And the patient was a clever clinician anyhow, later developed a GTC, but a clever clinician did AN and BSDNA, which was positive, and subsequently the patient developed cutaneous manifestations. Patient was managed as, subsequently managed as CNS lupus. This is another case where 35-year-old female patient was treated for pyrexia of unknown origin with a 1-year history of rash. Basically, the septic screen was negative, and 2D echo revealed pericardial effusion, BSDNA negative. There was low completeness. Skin biopsy was suggestive of acute lupus. So, if you look at all these cases, these are not typical ones. These are the ones which we see in clinical practice and sort of try to sort it out whether this is lupus or not right at the beginning. So, what we need to remember is during the early stages of the disease or during the rare presentations, we might not be able to diagnose lupus at the right at the beginning, or we might not think about that. And also, when cases sort of we are our heads or the brain is trained to say that ANA positivity is always associated with SLE. So when we tend to disregard lupus when the AN is negative, which is wrong. So I always like to explain this basis of connective tissue diseases with this. This is a sort of a jigsaw puzzle. You would not see all the clinical manifestations of a disease right at the beginning. You would see just bits and pieces, possibly a hair loss, maybe a little bit of photosensitivity, but later on, the patients tend to develop other clinical features. So, what we have to remember is connective tissue diseases evolves over time. We might not see the full picture at the present. So we need to follow them up. Patients with early disease always need to be followed up. If they evolve from, because they would evolve from undifferentiated status to a differentiated one. So we might see a lupus nephritis, which might evolve into full lupus picture with the CNS lupus. So why we struggle with lupus is diagnosis is because we have been we were not able to recognize what the difference between diagnostic criteria and classification criteria are. So even now, we tend to put, when a patient comes to us, tends to look at the criteria and say that this patient does not fit into a diagnosis of systemic lupus, which is wrong. Because all these lupus criteria are classification criteria, not diagnostic one. What we have to remember is lupus diagnosis is essentially clinical, supported by laboratory investigations. What do you mean by a diagnostic criteria? Diagnostic criteria is a criteria where you would make a diagnosis in an undiagnosed patient based on a set criteria. But these are classification criteria where you would be say clinically diagnosed SLE patient to see if CO heat sets into or fits into a clinical trial in SLE, you use the classification criteria. So the problems comes when we all apply classification criteria to make diagnostic criteria. I'm not going into details about these 1997 criteria because nowadays it's been rarely used, and it originally was published in 1982, and 1997 device criteria was the initial 1982 criteria revealed that the presence of LD cells, which obviously I don't think nobody has seen in this audience. So it was replaced by number 10, where there was a number 10C, where positive finding of antiphospholipid syndrome was taken into account. Subsequently, 15 years later, SLICC classification criteria came into being, where you need 4 criteria again, with at least one clinical and immunological criteria. But this 2019 criteria is more comprehensive, where this is the first time you would see a weighted criteria. So this has a requirement for entry criteria, where there is a ANA positivity of 1/80 on a HEP2 cell base. And what we mean by a weighted criteria is, if the simplest thing to explain is mucocutaneous manifestations, non-scarring alopecia. So anybody, a female, I would say, in this audience might have experienced an non-scarring alopecia in his sort of telogen effluvium and all, at any point of her life. So, but it could go only 2, whereas the acute cutaneous lupus rash or male rash would score 6, giving more weight onto the diagnosis, and ultimately you need at least 10 marks of this weighted criteria to come to a diagnosis of SL. So still, what we have tried is sort of sorted out was the classification criteria. Now, the scientists or the researchers have tried to sort of incorporate these classification criteria into clinical practice, because everyone are looking for criteria. So now recently this was published, where you would be suspecting SLE is based on the positive ANA. If ANA is negative, you would still can count it as a clinical SLE based on, if ANA negative, there is one pathway to go in, that is look at hypocomplexemia, or if the patient has a positive APL, you would apply the EULA ACR 2019 criteria and make a diagnosis of clinical SLE. And if it is ANA positive and the patient is unable to count more than 10, still patient would be looking at, we would be getting ACR photosensitivity from 97 criteria, and she fulfills more than 2 immunological criteria or clinical criteria of more than 6 to diagnose clinical SLE. So if you remember this, I think most of 50% of my job is sorted out. Because remember, connective tissue diseases evolve over time, may not fulfill or diagnostic criteria at the very beginning. So they go into an undifferentiated state, from differentiated, a sort of undifferentiated to differentiated state over time. And more, the thing is, take home message from here is diagnosis of SLE is clinical, as I mentioned, supported by laboratory investigations. And there is no such diagnostic criteria for SLE, and classification criteria fulfillment is not essential to diagnose SLE. So next time you come across a patient like this, you would not disregard and say this is not SLE. So if maybe you might come across a patient with ANA positivity, refer to you for Castleman disease or Kikuchi. There was a patient I saw in Kurunagala 1 year back, where the postpartum mother came with retroperitoneal hematoma. secondary acquired hemophilia, ultimately diagnosed as SLE, and also patient with positive variant peripheral neuropathy. All these might be SLEs, which you might miss at the beginning if you don't or stick to the classification or criteria alone. So the second part of the lecture, I will be talking about disease activity assessment. So why do you need a disease activity assessment in SLE? As mentioned previously, why we need a disease activity assessment is these are multi-system disorders, and disease activity assessment would produce you a sort of an objective analysis of the disease activity, and it can be used as a monitoring tool for treatment. There are a number of setting active indexes, sort of activity indexes. SLE disease activity index, or the second one is the BILAC, or SLENA-SLEDI PJ assessment. But for me, most of the clinicians uses this SLEDI 2K version of SLEDI. Why we use this is, for me personally, I generally use this when I come across a patient with lupus flare, because I always, when you tick a box, you might not miss certain things. So let's say diagnosed patient with SLE comes to me with a cutaneous flare. If I tick these activity boxes, I would be looking at the UFR as well. Yeah, I won't miss a possible lupus nephritis flare or simultaneous lupus nephritis flare. So that is the most important thing. Even if you don't have time, I'll just give you an outline of this. This is the activity index, and I myself have never tried this in real life because I always use an app and get the things, make the things easy. So, but again, assessment through activity index might not be adequate if you don't use your clinical expertise. So I'll be talking about two cases here. A case of 45-year-old patient, again class 4 lupus nephritis, who had received cyclophosphamide pulses in 2020, maintained on MMF and HCQ and state steroids. Then later on 2021, April, she presented fever headache and altered level of consciousness of 2 weeks duration, where she had oral ulcers and sinusitis. There was a noted leukopenia and thrombocytopenia with raised inflammatory markers. UFR had no active segments. Septic stain negative. This was during the COVID outbreak, where there was COVID PCR was negative, CT brain normal, EEG diffuse slowing of waves, and subsequently she developed a GTC and has SLEDI 2K score of 33, indicating a severe flare. On the other hand, you have a similar patient with who had a TTP in the past and lupus nephritis in the past, comes with recurrent fevers, non-specific abdominal pains, and sort of constitutional symptoms. Again, she marginal thrombocytopenia, which you want sort of consider raised inflammatory markers with a normal creatinine and a sterile pyruvate. Ultrasound abdomen normal. So the outcome, this patient also has a moderate lupus flare if you put it into the SLEDI activity index scores, because fever and presence of sterile pyruvate counts for certain marks. But the outcome here differs. The case 1 was obviously a CNS lupus, where she was admitted to the ICU, ventilated. She received 3 pulses of MP pulses, and subsequently oral steroids were started and tailed off, followed by cyclophosphamide pulse. On day 10, actually, she started to recover, where there was the maximum effect of cyclophosphamide pulses. On the other hand, case B had to undergo, with the clinical judgment, had to undergo a colonoscopy, where there was ileocecal valve, ulcers suggestive of ileal TB. CT again shows thickening of ileal with ascending colon, sort of ileum and ascending colon with enlarged parietic retrocable celiac lymph nodes enlargement. There was a positive ideal biopsy suggestive of granuloma indicating TB ileitis. So she was started on anti-TB treatment. So take-home message from that is fever can be a sign of both SLE flare and infection. Infections are common in SLE with C4 deficiencies. Also, the patient is almost in immunosuppressed states. Again, tuberculosis is common and extra pulmonary manifestations are commoner than the pulmonary one. So basically, if you are just hunting for the chest X-rays and all, they might be negative, and even the sputum AFPs may be negative. So remember, just applying a Slater-Slidite criteria of disease activity might not alone would be helpful, because you need to apply it with the clinical sense. So getting back to the treatment of lupus. So obviously, as you all know, treatment of SLE is multidisciplinary, and the first described sort of EULA, European League Against Rheumatism or Alliance Against Rheumatism, first described the management of SLE in 2008, and there's an updated version, very comprehensive one in 2019. So treatment goals would be long-term patient survival, prevention of organ damage, and optimization of health-related QOL. So when it comes to rheumatology, the developments of other fields of rheumatology, when it comes to the diagnostic tools and the treatment, were far more ahead when compared to the SLE, because if you consider rheumatoid arthritis, there are MSK ultrasonography developments with a number of biologics coming into the picture. But still, treatment options available for lupus goes on a tortoise pace. Maybe because it's not lucrative to research on it. But still, this picture, this kind of SLE. The main important thing is whether it's mild, moderate, or severe forms of lupus, all needs hydroxychloroquine if there is no contraindication. Rule out the risk, that is higher doses, total duration, or presence of CKD, and pre-existing macular and retinal disease. The dose of hydroxychloroquine is 5 mg per kg per day. So how are we going to give 5 mg per kg for 60 kilo patient? So it would account for 300 milligrams, whereas the hydroxychloroquine tablet is only 200. So usually the practice is 300 into 7, it's 2,100. You would give 200 BD for 5 days and give a drug-free interval during the weekends. So don't go above the maximum dose is 5 and don't give a therapy. Then, when it comes to glucocorticoids, it would rapidly bring down symptoms, controlling, but medium to long-term goal is to bring the dose below 7.5 mg per day. No treatment guidelines are available to how to taper off steroids, but one would say to bring it down quickly. If you give an IV parental form or some sort of parental form, you might be able to bring it quickly. And also, you might be able to start off with your oral steroids at a lower dose than the 1 milligram per kg dose. Secondly, you might be able to bring down steroid pretty quickly if you start on an immunosuppressant drug right at the beginning. But there may be worries of starting immunosuppressant drug right at the beginning because most of the people during the flare would have a leukopenia or a neutropenia. So once the neutropenia picks up with steroid, you must start on an immunosuppressant agent. In milder forms, you might use the MTX or azathioprine, or severe forms, the MMF, and in persistent cases, there's the option of using belimumab, which is a BLyS inhibitor. In severe forms of diseases, like in CNS lupus and lupus nephritis, I'm sure that my nephrology colleagues would be talking about the regimes and all, would be using cyclophosphamide or the rituximab. There is also adjunct treatment where it's crucial to implement the sun protection, at least SPF 50 or above, and look into the metabolic parameters with weight reduction, controlling hypertension, and cessation of smoking. And to initiate antiplatelet and anticoagulant treatment in cases of APL positivity. What is the ultimate target of treatment? So we are treating, as for rheumatoid arthritis, we are treating for a target. That is to go into a remission where SLEDAI score would be 0 with HCQ alone with no glucocorticoids. Or if that is not practical, to go for a low disease activity where the SLEDAI score would be at least less than 4. The patient should be on hydroxychloroquine with the minimal dose of prednisolone less than 7.5 with the stable dose of immunosuppressive treatment. I'll just touch on NPSL management, but to sort of identify the crucial points in that, we need to go for or go into the NPSL pathogenesis for a little while. So there are two sort of neuropsychiatric lupus is related to two sort of pathogenic counts where there's an ischemic component and an inflammatory component. If ischemic component gives rise to thrombosis, where there's a complement activation and angiopathy, leading to focal neuropsychiatric manifestations such as stroke or diffuse ones, cognitive dysfunction. On the other hand, inflammatory components give rise to focal neuropsychiatric manifestations such as seizures and the diffuse ones such as psychosis. But you need to exclude other possible causes for CNS sort of mimics of CNS lupus such as uremia, hypertension, complications of therapy, psychosis related to corticosteroids, or infections. So, identification of this part is very important because if it is a sort of, the guidelines would say, EULA guideline, if it is an inflammatory component, it's glucocorticoids versus immunosuppressants. In the presence of antiphospholipid antibodies, if you suspect the thrombotic pathway, it's anticoagulants and antithrombotic management. But in cases, if you find a cognitive dysfunction, you give a sort of a mixture of both. So treatment of NPSL, again, corticosteroids after excluding other non-anesthetic causes, IV methylprednisolone pulses with plus or minus cyclophosphamide. Gradually tail of steroids. Little evidence for MMF or azathioprine, but important thing again is hydroxychloroquine. It reduces seizures. Refractory cases should have rituximab, not belimumab. Belimumab is not licensed for severe forms of SL. You might need antiplatelet, anticoagulated therapy if APL antibodies are positive, or specific additional therapies for recurrent seizures. We generally don't start on epileptic treatment for a case of a single episode of NPSLE. If you have recurrent seizures, you might consider adjunct treatment therapies. So this slide summarizes the potential impact of a treat to target strategy. So this is the conventional approach where you would have a roller coaster kind of a flares leading to a higher morbidity and mortality with accumulation of damage. But if you stick to a treat to treat strategy, you would end up with a lesser damage and lesser comorbidities and a good patient survival. So the final part of it, I would be talking about chronic damage in lupus. So this is a patient I met in Mandalay. I would call, she's a 25-year-old patient with SLE, diagnosed in 2020. She had severe cutaneous disease and she had class 3 lupus nephritis in 2021, where she received rituximab. Had a single episode of alteration of the level of consciousness, which was treated as NPSLE in 2021. But the main problem in her management is she has transgender issues. She believes DLE is making her more masculine and doesn't want us to treat her scalp, leading to frequent flares. And each time she comes back to us, she accumulates chronic damage because we are topping her up with steroids. In her management, there are things related to transgender treatment because obviously a psychiatric needs to need us to tell that she doesn't have NPSLE. But in the presence of extra cerebral manifestations, it's so difficult for us to say that she doesn't have NPSLE because she needs to go into a sort of a probation or some, as a word might not be the right thing, for 2 years before she tries on endocrinologists look into the possibility of androgen therapy. So again, androgen therapy would make her prone for atherosclerosis risk or increases atherosclerosis risk in her, and there may be impact on osteoporosis as well. So this, so why chronic damage in SLE is important? It results from both the disease itself and the treatment. Sorry for this. So I don't know why it's not coming up. The one, yes, treatment with the steroids and immunosuppressants increases the chronic damage, and also the disease activity increases the chronic damage, leading to higher mortality. So assessment of chronic damage in SLE will predict the future mortality in SLE patients. And obviously, having pre-existing damage increases the future damage which accumulates. There are modifiable risk factors that can be targeted as an integrated strategy. So what we use for chronic damage assessment is the damage index, or the SDI, where it measures the irreversible damage. So damage index measures non-reversible damage not related to acute inflammation. It's been scored from the time of SLE diagnosis, irrespective of whether or not damage is attributed to lupus. So let's say a patient develops a diabetes after the diagnosis of SLE, you count it as a chronic damage, sort of which you count it as a chronic damage in the index. And it is ascertained by clinical assessment, not by investigations and so on. Items should be present for at least 6 months, the exceptions being strokes or myocardial infarctions. You can't score the same lesions twice, and there are 12 domains with a maximum score of 47. This is the SLICC damage index. It's very nice to get it done time to time on a time-to-time basis. But there are limitations of this damage index. This is the only damage index which is available. But the limitations include there are updated newer definitions for osteoporosis, pulmonary artery hypertension, even CKD for renal impairment, they would say estimated GFR of less than 50, they would 0.1, proteinuria of more than 3.5. So, but nephrologists would have more important things to look at in the damage context. But this, unfortunately, this has not been updated yet. There are items with impact which are not being considered: obstetric complications, infections, and Zika symptoms. And there are availability of newer diagnostic investigations such as DEXA scan, MRI, CTs, which would sort of sharpen up the items in the damage index, but still we go for clinical assessments. So the other thing is, it's been calculated from the time of the diagnosis. Whatever which has happened prior to the diagnosis are not taken into the consideration. And finally, what is the prognostic implication of this damage index? Because a cataract would give the same score, whereas myocardial infarction and cataract would give the same score of 1. The duration is 6 months too short. The 6 months window reflect the true damage. So what is most important thing is you identify the damage and then you manage it according to a multi-dimensional approach for damage control in SL. You would optimal control of the disease activity, minimize or avoid steroid intake, as I mentioned, commence immunosuppressants early, use of parenteral treatment at the beginning might also help, optimal control of hypertension, and most importantly, use of hydroxychloroquine. So finally, I would go back to my first slide where I said that there would be with the repeated flares or the persistent disease activity, there would be an accumulation of damage. So I talked about these things today. Diagnosis should be clinical, or SLE diagnosis is clinical, not, there is no diagnostic criteria or classification criteria diagnosis SLE, and interpret your ANA carefully. The second is disease activity assessment used with a clinical judgment, and management is multidisciplinary, but most importantly, it's to treat to the target. And finally, chronic damage, only index you have is the SLSON in damage index, but the management wise, it's multi-dimensional treatment or model that you are using. So I must thank once again President and the college council members of both the colleges. And I must thank my trainer, Dr. Devindu Munidas, because some of the cases are his. And all patients, lupus patients I met at Raghavan and RH, the UK, and previous workstations of DGS Nurelia, Kurunagal, and Mathale, from whom I learned the art of lupus management. Thank you very much.
afternoon, everyone. So thank you very much for the opportunity to speak today. And I'm Dilukshi Pilapitia, and my topic is to add to my previous colleague's lecture on lupus to tell the kidney part of it. So my outline will be, I'll be just presenting one or two cases and then to talk on the statistics of just one slide. And this is my outline basically, and to recap on the new guidelines also. So among patients who are already diagnosed with SLE, there's a 20 to 60% lifetime risk of getting lupus nephritis. So it's quite common to see lupus nephritis among SLE patients. And so why is it so important to diagnose lupus nephritis early, if at all? So in a patient with lupus nephritis, within 5 years of the onset of the proliferative lupus nephritis, there is a chance that 5 to 25% of them might die to a cause attributable to the kidney disease. So it's important to diagnose and to manage early. In this American Journal of Kidney Disease update, it says that 10 to 30% of patients diagnosed with lupus nephritis do progress to renal replacement therapy despite the novel treatment options available and advances in medicine. And achieving a complete clinical response to treatment is critical to preserve the long-term kidney health. So this is why it's important. So case one is quite straightforward. I won't waste time on this. This is a 32-year-old female with a background autoimmune sort of history with just presenting with ankle edema. It's quite straightforward. When they come like this with a marginal blood pressure with a UFR, which is showing 2+ proteins, generally we tend to think about SLE also as one of our main DDs, and we do the immunology, which detects it. Quite straightforward. So it's a usual. So females of childbearing age presenting, maybe related to pregnancy or not, but with features of SLE, that's straightforward. So the case 2, this was presented to Srijadapur about a couple of months back. 18-year-old boy who had a previous history of ITP, but resolved with treatment and therefore not further followed up. So he presented with fever for 2 weeks. It was managed as a PUO in the medical ward when the proteinuria developed and we referred and we took. So he had joint pains and oral ulcers, and he also has had bilateral cervical and axillary lymph nodes with mild pallor and ankle edema. So with investigations initially was quite complex. He had a pancytopenia, and ESR was high and CRP almost less than 50 all the time in the initial period, and creatinine was just on the margin for his age, and he had high ferritin also, and also he had a myosplenomegaly with a marginal UPCR. So his biology was negative. And the CSCT showed that he had generalized lymphadenopathy. So the DDs of lymphoma, whether this could be this the lymphoma with the initial presentation of ITP was on the cards initially. So one would be reluctant to suddenly immune suppress these patients at the outset. And we couldn't do a biopsy in the beginning because of the platelets was always around 20s, 30s. But luckily the bone marrow was done, and then it was no lymphoma leukemia. So they started steroid pulses. And the lymph node biopsy said that it has a necrotizing lymphadenitis favoring Kikuchi. So Kikuchi is a self-limiting disease. Always, I mean, there's so much association to SLE. And generally in Sri Lanka, still there is a lag behind time in getting the immunology reports on time for us to make diagnosis. But when it comes, it showed that it is towards SLE. So we did the renal biopsy, and it was class 4 nephritic with full house pattern. So the unusual is when they present in an older age group, we generally tend not to think of SLE as a DD, but we should. So during my foreign training period, we have seen enough even older males getting lupus nephritis. So therefore, that should be a DD when they present in the old age also with unexplained elevations of creatinine. Even though they have underlying diabetes, it should be borne in mind to look at the UFR and that sediment. So the risk factors for lupus nephritis and for them to get more aggressive disease with it, being male sex and being younger in the age are important risk factors. And African Americans, Asians, Hispanics when compared with whites. And also they tend to get more aggressive disease when the lupus nephritis presents more earlier in the SLE disease course than later. And HLA, DR3, DR13, and APOL1 genes also have more aggressive disease. So the ways to detect, just to recap for the new registrars who are starting. So so for early detection, you should look at urine dipstick, urine sediment examination, and the quantification of proteinuria with creatinine levels. So initially, when a patient is already diagnosed with SLE and doesn't seem to be having any nephritis involved, I think would for the first 2.5 years, we should be looking at these things maybe about every 3 months, and then at least annually thereafter, or when we think that there is a flare. So what are the caveats in looking at the urine? So the urine dipstick can be falsely positive in people who have high specific gravity. So it's important to look at the specific gravity also in the urine part. And non-glomerular bleeding in females, or maybe even just catheterized samples, can also have false positives. That's important to bear in mind. So in such cases, you should always repeat and to make sure that where it is going. And it can be false and negative in low specific gravity as well. So if a patient's UFR shows 1 plus protein, but the specific gravity of the urine is low, we tend to take that a bit seriously and try to quantify it. So to circumvent this, you should always look at the urine microscopy, or what we call the sediment examination. So this is again showing that dysmorphism and the acanthocytes, which direct towards the glomerular pathology. So this is showing the dysmorphism and the spike cells are acanthocytes. So this is our RBC cast and this is a WBC cast. So microscopic hematuria is generally present in about 80% of SLE patients and casts in about 30% of patients. So WBC casts in the absence of inflammation also suggests intrarenal inflammation. So therefore that also we take seriously in SLE very patient. Proteinuria, nephrotic rate is seen only in about 50%. So subnephrotic should be taken seriously and quantified. So the probable gold standard would be to do a 24-hour collection, especially when you are doing the first training, not to miss, because the UPCR taken as a spot sample may under or overestimate the proteinuria. So it's the UPCR test that can at least come close to 24-hour collection is the morning first white sample, which we would do if the 24-hour collection is cumbersome or hard to do at that particular moment. So when to biopsy, I'm sure you all know this, proteinuria more than 500, decreased GFR for unexplained causes, active urine sediment, which is at least 1 cast of either of this, and more than 5 RBCs, of which most of which are dysmorphic. So remember the caveats in looking at these results. So for a biopsy sample to be taken as adequate, we think that at least 10 logs should be there in the sample, and we should send for light microscopy plus immunofluorescence. Of course, EM facilities are not readily available in Sri Lanka yet. So how would renal biopsy help? So it is important to class differentiate and also to look at the activity chronicity source. These are important in taking further management decisions and prognosify. And we can also detect the non-glomerular nephritic problems in the kidney, that is podocytopathies, tubular interstitial nephritis, underlying TMAs. So this is important, the biopsy is important to detect these. And very rarely, although we think that it is SLE, we sometimes may be able to detect other maybe drug-induced problems that is causing tubular interstitial nephritis, causing all this, so hypertensive glomerulosclerosis, IgA nephropathy, and things like that also can be detected from there. So there are 6 classes in SLE about kidney pathology. So class 1, generally it is detected by IF positivities only because the light microscope is normal. In class 2, as you see, there are more than 3 to 5 cells in the mesangium. So this is called mesangial proliferative glomerulonephritis. So this is class 2. Class 3, it can be active, inactive, or global segmental. So this is a necrotizing crescentic lesion seen here. So when it is called class 3, when the lesions involve less than 50% of the glomeruli, whatever the lesion. And when it is involving more than 50% of the glomeruli in the kidney biopsy, then we call it class 4. So when I want to highlight a viral lesion here for those who are interested, because when there is immune deposits in the glomerular capillary wall and it picks out like this, it's called a viral lesion. So when this lesion occurs, generally it's very diffuse disease and generally it's seen in class 4. So class 5, you see membranous glomerulonephritis here with deposits in the subepithelial membrane, and also there are some reticular lesions here. So this is the IF pattern. We call it a full house pattern because generally we do IF on IgM, IgG, IgA, C1q, and C3 kappa lambda. So anything can be positive in SLE. It's called a full house pattern. Particularly C1q is fairly specific for SLE. Right? Full house pattern can be a DD for other things such as polysystemic shunts and a few other DDs, but those are seen very rarely. Class 6 is generally a very slow depicted by a slow progressive decline in the kidney function with protein and relatively a bland segment. So in this stage, there's extensive scarring already with glomerulosclerosis with more than 90% of the glomeruli. It's important to identify this because unnecessary immunosuppression is more harm than benefit. Treatment, we all know that there's induction and maintenance phases, but which I will talk about in the next slides. But it is very important not to miss that these SLE patients are having a high inflammatory state in their bodies throughout due to this disease. So therefore, they have more serious risk. It is very important to highlight this to the patient, maybe in the recovering phases, to tell them that their lifestyle should be modified because they had SLE and that can be a chronic condition which can be there in their body. So therefore, they should have lifestyle modification advices given. For example, exercise and smoking cessation, weight modification, all should be told to the patient. It is important. And this, of course, we know when proteinuria is there, we should avoid high sodium diet, and blood pressure control is important. They're always having infection risk because of the immune modulated treatment that they're giving. So therefore, we should be having a look out for PCP prophylaxis and the necessary vaccinations that needs to be planned on a patient who's supposedly going to have a long-term immunosuppression plan. And we shouldn't forget their bones, to do a baseline DEXA and support their vitamin D levels, and also to ask them not to be exposed to the sun and wear sun protection sort of creams, and also to important advice against unplanned pregnancies. And also they're also having slightly more lifetime risk of malignancies due to the drugs that they're getting, plus due to SLE itself. So there are non-Hodgkin's lymphomas, lung, liver, vaginal cancers, thyroid cancers, which can be increased. But guidelines still suggest that their screening as per normal population is enough, but they should be made aware. So this is KDIGO 2023 have put out a new guideline. So that's what I have looked at for this particular presentation. So class 1, 2, if they have low level of proteinuria, their general management is directed by extrarenal manifestations, which my colleague discussed about earlier. But if they do have nephrotic syndrome, that is more than 3.5 grams, then the EM sample of that BARBs that we did is very important because that is the one which is going to detect the diffuse effacement of food processors. So in which case, then it's likely to be a lupus polycythopathy. If we didn't do an EM, there's a chance that we may miss it and we think that it's a minimal change disease. Anyhow, even if it's a lupus polycythopathy, it's generally very steroid responsive. So the management will be more or less towards managing a minimal change one. So class 3, 4, the recommendation is that if there's active class 3 to 4 lupus nephritis, it can be with or without class 5, the membranous component. So you anyway give a glucocorticoid plus. These are the 4 options that they recommend now. Either a MMF, mycophenolate mofetil, or a low-dose intravenous cyclophosphamide. So there's no question about standard dose or the oral because those are more toxic. So low-dose intravenous cyclophosphamide. And then there are these 2 new options available, which is belimumab, either with a MMF or a cyclophosphamide, and MMF with a CNI in patients who doesn't have severely impaired kidney function. That is, if their GFR is not below 45. So, and also in class 5, the membranous lupus nephritis, again, if the proteinuria is low, then we can give supportive medicines like CQ and the RAS blockade, and the immune suppression is directed by the extrarenal manifestations. But if they have nephrotic syndrome, so then they should be given immune suppressants according to our protocols. And also in membranous, we shouldn't forget the risk of thrombosis. So therefore, we should bear in mind to give DVT prophylaxis. So a regime of reduced dose glucocorticoids following a short pulse of mifepristone may be considered during the initial treatment of active lupus nephritis when both kidney and extrarenal disease manifestations show satisfactory improvement to the initial pulses that we are giving. So the pulses that they recommend now in all three regimes is generally about 500 milligrams per day for 3 days is sufficient. We tend to give sometimes 1 gram per day for 3 days, and which is not supported by the guidelines put out in the 2023. So 500 milligrams per day is enough. And if they show adequate or very satisfactory response to that, we can choose this reduced dose scheme, which shows that we can start off with 40, and then by about 3 months, we can bring it down to 5. So which reduces the glucocorticoid burden for these patients. So intravenous cyclophosphamide should be used as initial therapy who may have difficulty adhering to any oral regime. So we have to bear in mind in this one is very important because there may be lupus patients who have a very severe flare, who might have GI upset. That GI upset can be due to the MMF that we are giving. But if we presume that they might recover from this and then just wait and watch, they might actually deteriorate and succumb because we haven't escalated our management. So therefore, we should bear in mind if they have a GI upset, it can be due to a lupus GI involvement or it can be MMF intolerance. So in such patients, it is very important that we escalate management to IV cyclophosphamide provided there is no bladder infection underlying. So in MMF-based regimes, it is preferred in like generally in patients, we want to preserve the fertility, or there is, or of course, previous cyclophosphamide exposure. So therefore, if we expose them again to cyclophosphamide, the cumulative burden of cyclophosphamide will be more. So the initial therapy with the immunosuppressives, which includes CNI. So CNI is calcineurin inhibitors, namely voclosporin, which is the new drug. So this is a new drug which is coming to the market. This doesn't need much of monitoring, which is I think most important beneficial factor of this drug. And then there are other CNIs, that is tacrolimus and cyclosporin, which needs monitoring, of course. So the CNIs may be preferred in patients who have relatively preserved kidney function. I highlighted this earlier. So who have a GFR more than 45. It's not recommended to give when it's less than 45 because of the nephrotoxicities of the CNIs itself. And also, especially when they have nephrotic range proteinuria, likely due to an extensive podocyte injury. So in such cases, the CNIs is shown to be beneficial. So it's like an add-on therapy to either the MMF or cyclophosphamide that we are giving. And the next point is, so a triple regime with belimumab addition. So this is considered in patients who have repeated renal flares. So we can think of belimumab, or if we think that there's high risk of progression, we can think of belimumab. So to talk about MMF, I hope people are aware of the ARMS trial, which said that comparing MMF and the cyclophosphamide, because initially in early 2000s, everyone was treating all patients with cyclophosphamide, which of course carried a lot of toxicities and risks. So then the MMF came to the picture after this ARMS trial said that it's equal to cyclophosphamide, so that it's easier regime to use. But the trial used a 3 grams per day dose. So then the follow-up studies show that there is high infection rate with this dose in Asian population. So therefore, follow-up studies showed that 2 grams per day is not inferior. So therefore, in Asian population especially, we advocate a dose of around 2 grams a day. So we generally give 1 gram PD, and we would think several times before bringing this dose up, I don't think as nephrologists, many nephrologists do not practice a higher dose than this. So drug level monitoring in MMF is not established, so we do not do that. Cyclosporin regimes, to make the words clear for the new registrars, so standard dose, NIH regime, high dose, all mean the same thing, versus low dose or Eurolupus. So both these words mean the same thing. So since this is the Eurolupus regime, which is now, these were used earlier, but this is what is in the middle is what is advocated now. That is IV 500 milligrams every 2 weeks for 3 months. So that is less toxic. Obviously, the oral cyclophosphamide dose, the cumulative doses are more. So this is discouraged. And comparing these two regimes, the low dose regime has equivalent efficacy. So that is what is advocated now. So coming on to maintenance, so class 3, 4, 5 all means maintenance drugs. So what is recommended is generally MMF, because in the maintain trial it said that the efficacy is similar, but the ARMS maintenance trial showed that MMF 2 grams is superior to azathioprine. So there are still instances which azathioprine can be used, that is when a patient is intolerant to MMF, or when the patient wants planned pregnancy, or there is no access for MMF. So now we are at the maintenance. So glucocorticoids should be tapered to the lowest possible dose during maintenance, except when glucocorticoids are required to extrarenal lupus manifestations. So glucocorticoid discontinuation is generally more and more encouraged with newer trials, because now the usual practice of continuing low dose steroids for eternity is likely. Many studies are putting the facts out that low dose maintenance steroid is not going to alter the course of the disease. So therefore, generally there's recommendations to bring them off the steroid if there's complete clinical response beyond 12 months. So in the patients with triple immunosuppressive regimes, it is also noted that the triple immunosuppressive regime should be continued in the maintenance therapy as well, because we generally tend to give this in more aggressive patients. If the MMF and azathioprine is not available or cannot be used for maintenance, then the options would be either CNI or mesorapine or leflunomide. Duration of maintenance therapy, there are a lot of studies for and against on many theories going on, and it is to be considered after at least 1.5 years of complete remission. So if there's persistent partial remission, of course, it is advocated to re-biopsy to see the state of the kidney underlying before thinking of taking the drugs off. And sometimes, or occasionally, some with repeated flares, there may be the best thing would be to continue indefinitely. So what is complete remission? So there were many guidelines and lot of literature on what is complete remission. So I took this out of KTO. So complete remission, so ease of remembering from this lecture something to take home with, I thought I'll highlight this part. So reduction of proteinuria to less than 0.5 in a collection. So this is called a complete remission in a patient. So persistent reduction in proteinuria. So what is a partial response? Reduction in proteinuria by at least 50%, or to less than 3 grams per day of a 24-hour collection. So this is complete remission and partial remission. So if these are not met, it's called non-responders. So in non-responders, what we should do is we should look whether they are adherent to treatment first before trying to switch or escalate the treatment. And then if they're really adherent, then there are other treatment modalities such as rituximab. So indications for re-biopsy is, so if we think that the patient is treatment resistant, is indication. If there's new unexpected flare, so maybe there's new proteinuria which is coming up despite adequate treatment, or new rising creatinine might be having class change, so therefore there can be presenting glomerulonephritis coming up, and active sediment after a quiescent phase, and suspicious of a class change in assay. So, or doubt whether disease is chronic. And we think that there's no point in escalation. This is also an important part. So then if we did a class 6 here, we might tail off the immunosuppression if we detect this in the biopsy. So as I said earlier, when thinking of withdrawing after we think the patient have achieved complete remission, it is supported that we do a biopsy if possible to make sure that things are all right in the kidney work, because 20 to 50% of cases showing significant histological activity while thought to be incomplete clinical remission in 6 to 8 months of treatment. So although we thought they're in complete clinical remission, they had some histologic activity. So there are studies which showed that if the activity scores are more than 2 in this kind of biopsy that we do when we consider to stop immunosuppression, if the activity scores are more than 2, then there's a chance of relapse if we stop immunosuppression. So 40 to 60% who had persistent proteinuria and we thought they are not achieved remission had no histological activity on repeat biopsy. So there are findings like that also. So that is why biopsy is important in these scenarios. So to tell about that now, sometimes patients come and ask for the prognosis. Now they have taken treatment for 1 to 1.5 years. So they say, doctor, now what is my next level? So now for that, protein excretion less than 0.8 grams per day at 1 year is generally a good predictor for good long-term prognosis. Antimalarial is something that we should not forget to add in all classes of SLE because it's an immune modulator, and also it has anti-inflammatory and anti-thrombotic properties. Also, it is safe in pregnancy. So it improves the 12-month renal response rates, it reduces flares, and it delays the progression to end-stage disease. So when given in pregnant patients, it reduces the small for gestational age babies by 85%. So it's important, and reduce the risk of congenital heart block in, sorry about the spelling mistake, anti-RO positive patients by 50%. Just a word about rituximab. So the Luna study initially had a problem with the trial design. So class 3-4 done within the last 12 months with proteinuria more than 1 gram. So there was a lot of heterogeneity in this study. So therefore, it showed that to use rituximab as an initial induction agent was not very supported. So the current use for rituximab is to use in resistant disease or as maintenance when a patient is MMF intolerant or the patient is refractory to other treatment. So there are several emerging therapies and a lot of trials going on currently for SLE, which are still under trial stage and not have been incorporated to guidelines. So, but development that I thought I should highlight is regarding obinutuzumab. So it's a monoclonal anti-CD20, which is a second generation 1-2 rituximab. So it's a type 2, the type 1, the rituximab is a type 1 anti-CD20 monoclonal antibody. Obinutuzumab is type 2 anti-CD20 monoclonal antibody. So it has encouraging results in its the RCT because the complete remission at 1 year is 40% compared with 18% in placebo. So the serious infections were also lesser, so it was not statistically significant at all. So it's safe, and there is remarkable BCL depletion response, and response was seen as early as 4 weeks. So this might be incorporated in the future. So a word about pregnant patient. So the patient sometimes come to the clinic and ask with lupus nephritis, doctor, can I become pregnant? So the advice is they have to be having quiescent disease for 6 months. So that means they have to be in remission for 6 months to try and avoid a flare during pregnancy. So we have to they should not, the quiescent period should not be a period where we are tailing down immune suppression as well. So they should be in remission with a stable dose. And in pregnancy, MMF we cannot give. So we have to wait for at least 3 months before, after stopping MMF to become pregnant. And we should convert that to azathioprine. And also we can continue the CNI, HCQ, steroid, and if necessary, we can give IVIG. Rituximab, there is no trial data. So therefore, it is advised to wait at least 1 year after the last rituximab dose because it crosses the placenta. Low dose aspirin should be added after 16 weeks. And also, if managed well, more than 80% pregnancies are uncomplicated. So we should not advise against also. So, but we should counsel them of possibilities because 20% can have lupus flares, lupus nephritis flares, and preeclampsia, HELLP syndrome, such complications can be seen about 11%. Fetal losses also seen about 8%, and preterm birth in about 30%. We should, so when we say avoid unplanned pregnancies, we should also advise them on contraception. So it is important to bear in mind whether the APLS antibody screens positive or negative, and the disease activity levels are moderate or high in SLE. So in such cases, we should advise against usage of estrogen containing methods. So we should advise them on getting progesterone-only methods. A word about drug-induced lupus. Generally, it's not seen. The lupus nephritis is not seen with drug-induced lupus. It's the other manifestations which are common, but it is not an unknown entity. So, tubular interstitial nephritis and nephrotic syndrome with proliferative glomerulonephritis can occur, especially with these drugs. TNF alpha blockers, namely infliximab heparin receptor and so forth, and IFN beta used in oncological practices. And about end-stage renal failure with lupus nephritis, more than being on chronic dialysis, preemptive transplants seem to have better prognosis for them. The lupus nephritis can recover after transplant in about 2 to 10% after about 4 years, most commonly seen as class 2 nephritis. But overall, patient and allograft survival in the studies are similar to non-lupus patients. So APLS also increases the risk of blood loss. So in the early post-transplant period, we should make sure that we give adequate prophylaxis for this. So just 2-3 cases, just recap on whether we learned some basics. So a 32-year-old female with a history of SLE-associated malar rash and polyarthritis is referred to you for evaluation proteinuria discovered by routine analysis. So which is correct in this one? Proliferative lupus nephritis does not occur with UPCR less than 1000. Is it true? And absence of dysmorphic red cells on urine microscopy rules out lupus nephritis. Is it true? Spot UPCR are unreliable for accurate assessment of proteinuria in patients with lupus nephritis. Is it true? And urine concentration, specific gravities does not influence interpretation of proteinuria. Is it true? Which do you think is the answer? Anyone? See, great. So another one, a 24-year-old woman with a history of lupus nephritis treated with low-dose cyclophosphamide, followed by maintenance MMF, presented for her 1-year follow-up. So creatinine level is 0.9 and proteinuria is 0.6. Her RBC is 1+ in the dipstick. So she's worried about her long-term kidney health and her renal prognosis. So which of this is true? She has a favorable long-term kidney prognosis based on the 12-month proteinuria level. She has a poor long-term kidney prognosis based on persistent hematuria. The combination of 12-month hematuria and proteinuria is more predictive of long-term kidney function than proteinuria, which is true. These are very basic questions. A is true. I highlighted that having less than 0.8 grams per day at 1 year is generally a good prognostic indicator. And this one, an 18-year-old woman with SLE has class 4 lupus nephritis. So she is treated with MMF and prednisolone. After 2 months of stable laboratory readings on treatment, her kidney function started to worsen with new onset hypertension. So over about 2 weeks, the creatinine increases from 0.9 to 3.5. Blood pressure is 160/90 while she is being adhered to treatment. So what will be the appropriate next step? So give the patient, given the patient is unresponsive to MMF, switch to IV cyclophosphamide or check APLS titers or increase the prednisone to 60, start the detox. Here, the B is taken as the answer because this can be a APLS catastrophic syndrome that she's going to develop to. So, because already taking treatment with adherence to treatment, we should always not forget to check the APLS antibodies along with the patient who's having SLE. So, thank you very much.
I would like to thank both the speakers. To save some time, do you all have some questions and do you like to have some active participation? So till we get some questions now, to summarize the lupus part, now we have learned that we don't use 1 gram methylprednisolone even in severe lupus nephritis. We stick to 250 to maybe 500 pulses. So remember that even in severe lupus nephritis, we use 500 milligram 3 days pulse. And then we rapidly taper steroids now as opposed to previous regimes. Then now we have 2 new FDA approved drugs, the B-cell stimulator inhibitors, the BLyS inhibitors, and the voclosporin, so which is coming slowly into the guidelines. So, but it's still not available in our country. And then we have rituximab. So, where do we use rituximab? Can I get some answers from the audience? So rituximab is used when there is subepithelial lesion, that is in membranous lupus nephritis. And then when you have resistance, severe resistant disease, also we try rituximab. And also in cases where you want to tail off the steroids for any other reasons, if you want to tail off the steroids, you can give rituximab and try to rapidly tail off the steroids. So these are some places we use rituximab, but rituximab not has come into the guideline as yet, except in the severe resistant lupus. Then HCQ is important in all lupus, and in you use half the dose when the GFR is less than 30. So 5 milligram per kilogram per day if the GFR is more than 30, and 2.5 milligram per kilogram if the GFR is less than 30. And don't forget to give RAS inhibition in all patients with proteinuria. So renin-mediated nephrosis resistant ACE inhibitors, if not tolerating ARBs, to all patients on proteinuria. And then remember that again the subepithelial lesions, membranous lesions takes time to resolve. So don't step up the immunosuppression quickly. So if you treat the subepithelial lesion, the membranous lesion, give at least 6 months to 1 year for to see the treatment response. The other lesions you have to rapidly step up, but subepithelial membranous lesion will take time to resolve. So after the initial treatment, give some time, 6 months to 12 years. Sometimes people respond even after 12 months after the initial treatment with membranous disease. And when to stop? And I think I saw one, we don't treat proliferative lupus with rituximab unless it's associated with membranous or membrane, unless severe. I don't know the way your patient was treated with rituximab in the was. No, it's not the universal acceptance by nephrologists. Then when to stop immunosuppression, it's $1 million question. Still, we don't have proper guideline. And in our setup, I'm very, very reluctant to stop steroids as opposed to in the Western world. So I would at least give 3 to 5 years of steroids before stopping it, but it might differ. So the guidelines up to 3 years. Be very careful when you stop steroids in lupus. Closely monitor, at least initially monthly. Right? So any other questions so far?
Just one question from the online audience. What is the place for repeat ANA in negative patients?
What is the place for repeat ANA?
Negative SLE.
Negative SLE. That's a question from the online audience. What is the place for repeat ANA negative patients?
ANA can be negative, particularly in the early stages of the disease. So there's a place for repeating ANA if the initial ANA is negative, but there is no place to repeat ANA if the initial ANA is positive. You won't go and repeat ANAs to look for the disease activity.
Yes, the previous speaker correctly pointed out, don't stick to one point. This is a disease which manifests over the period of years. Don't look at only one point. Just because ANA is negative doesn't mean it cannot get SLE. So look at the whole pictures, have a longitudinal follow-up and coming to get into diagnosis.
Yeah. So as Amal said, it's diagnosis of SLE is mainly clinical. Right. So unfortunately, we are running behind the time, more than half an hour. Just a reminder, but I would like to.
There's one more question. Hybrid audience.
So where do we see?
Raise the hand, sir. You have muted the slide.
Yeah, only one I can't see. one question that we answered.
Okay.
Yeah.
Thank you.
That has been answered. Okay. Right. So I would like to start the next session, that is on vasculitis. I would invite my colleague and senior consultant rheumatologist, Dr. Monica De Silva, to talk on vasculitis, clinical presentations of vasculitis.
Good afternoon. Thank you, Chairperson Madam, for kind words of introduction. And I would like to thank College of Specialists in Rheumatology and Rehabilitation, Sri Lanka, and Sri Lanka Society of Nephrology for organizing this important CME event and for inviting me to do this presentation. So I will be discussing on clinical presentations of vasculitis with renal involvement. So in next 25 minutes and so I will discuss, particularly I will concentrate on non-renal manifestations of vasculitis affecting kidneys. So it's mainly the small vessel vasculitis affects kidneys with the glomerulonephritis. And so it will be mainly on NK-associated vasculitis and immune complex mediated small vessel vasculitis. And this will be a case-based discussion. So this is a very familiar diagram, 2012 Chapel Hill Consensus Conference nomenclature. According to the vessel size, the vasculitis is classified, and large, medium, and small vessel vasculitis include, as I told earlier, immune complex small vessel vasculitis and NK-associated small vessel vasculitis. So there are secondary vasculitis as well, vasculitis associated systemic disease, either with lupus, rheumatoid, Sjogren, or sarcoid, and also vasculitis associated with probable etiology, could be due to drugs, infection, or malignancy. So there are three NK-associated vasculitis: granulomatous polyangiitis, GPA, with the granulomatous inflammation, and microscopic polyangiitis with necrotizing vasculitis but without granulomatous inflammation, and eosinophilic granulomatous polyangiitis with eosinophilia and granulomatous inflammation both. GPA or granulomatous polyangiitis, earlier known as vaginous granulomatosis, is characterized by presence of necrotizing granulomatous lesions of respiratory tract, vasculitis, and glomerulonephritis. So this is the patient with the GPA. So GPA is the commoner vasculitis seen by us, and 56-year-old man who presented, who was diagnosed has GPA 20 years ago. It was an incidental finding of chest X-ray lung nodule, and excision biopsy had been done, and histology showing fibrinoid center with granulomatous reaction, and CME also was positive. So patient was a seaman, so he was lost for follow-up. And after that, 10 years later, he has presented with presenting glomerulonephritis with RPGN, and at that time he was treated with plasma exchange and IV cyclophosphamide. And after that, he was on azathioprine, and this time followed up regularly on azathioprine. And then 3 years ago, he presented with nasal discharge, epistaxis, and nasal crusting. So you can appreciate the presence of bridging of the nose due to nasal cartilage collapse in his facial photograph. And then last year, he presented with nasal crusting and persistent headache. He also found to have active renal involvement, probably with renal flare as well. And ideally, this time, so you'd have treated with rituximab because he was treated initially with cyclophosphamide. And with this time, renal flare, probably treatment with rituximab is needed. However, now he's in remission following treatment. So what are the pulmonary involvement of GPA? So it's common, like almost 90% of patients with GPA get pulmonary involvement over the course of disease. It may be nodules or masses, and these nodules may be cavitating and usually multiple, but single nodules also can occur and can occur all over the lung. And there can be fluid levels as well. And there can be hemorrhage surrounding these nodules or consolidation. And these are seen or imaged better in CT scans of the chest. So it's about a 66-year-old man presenting with dyspnea, hemoptysis, and epistaxis with fever of 3 days. And he also had reduced urine output, oliguria, and swelling of the lower limbs of 1 week duration. And there was history of loss of weight and loss of appetite and loss of weight during few months. So that is very important symptoms that we have to get from the history. Usually GPA, these patients can present with a history of weight loss for few months. So, or sometimes they can present acutely, but these constitution symptoms always we have to look for. And he also had inflammatory type joint pain and myalgia without muscle weakness. And with direct inquiry, so we got to know that he was having hearing impairment, which was there for 2 years. And he was dyspneic and hypoxic, and examination there were coarse crepitations bilateral in lungs. So his ESR, CRP were very high with neutrophil leukocytosis, and there was macroscopic hematuria as well, and then urine also showing red cells, pus cells, and subnephrotic proteinuria with very high serum creatinine. So this was after, so he also had 2 episodes of hemodialysis. And even after that, so this, when he presented with this dyspnea and hemoptysis, he also had very high serum creatinine. And chest X-ray, there were diffuse opacities, and HRCT confirmed, HRCT was compatible with pulmonary hemorrhage. And his anti-glomerular membrane antibodies were negative. So whenever there is pulmonary hemorrhage, we have to look for anti-glomerular membrane antibodies. And his Cianca was positive and Pianca was negative. So diffuse alveolar hemorrhage, so can be seen, can occur in about 5 to 15% of patients, and it's clinically present with hemoptysis and anemia. There can be anemia and diffuse alveolar hemorrhages in infiltrates in imaging. And but these are non-specific findings. These can be due to infections. And even the imaging is non-specific, can be due to infections or bleeding from larger airways, and bronchoscopy is needed to exclude other causes of diffuse alveolar hemorrhage, like bleeding from larger airways. And presence of more than 20% of hemosiderin-laden macrophages supports the diagnosis of diffuse alveolar hemorrhage, so which need plasma exchange. Particularly if there is hypoxia, plasma exchange is needed for treatment. So this patient had hearing loss which was going on for 2 years. So upper respiratory tract involvement is common in GPA, occurs in about 70 to 100% of patients. and may be the first manifestation of the disease. Nasal and paranasal sinus involvement are the commonest, but otological involvement also may be the first presentation. So it includes serous otitis media, chronic otitis media, and there can be sensory neural hearing loss, even conductive deafness and mixed hearing loss also possible. And there can be vertigo, or there can be facial nerve palsy, usually associated with otitis media. So, this is a 32-year-old female who was referred to us from eye hospital. So her initial presentation was proptosis of right eye at 12 years of age. And 2 years ago, he had RPGA and ANCA was positive, but at initial presentation, ANCA was negative at 12 years of age. This is at 30 years of age. And at 30 years of age only, she presented with RPGA. And that time she was treated with IV cyclophosphamide. And then this time presentation was with pain and reduced vision in the other eye. The right eye already there, it was blind. So because it was initially proptosis was treated with shorter course of steroids, and it was ANCA was negative, so it was not considered as ANCA positive vasculitis. And the following contract of these inflamed tissues, there is inophthalmos as well as blindness of the eye. So this time ophthalmological diagnosis was peripheral ulcerative keratitis. So what are the ophthalmic features of GPA? So this also can be the initial manifestation in about 15% of patients, and can involve any structure of the eye. Scleritis is the commonest, and usually it's present with pain and redness of the eye with tender eyes. And peripheral ulcerative keratitis present with diminished vision and some pain, and that's also a common presentation. And any, as I mentioned, any structure of the eye can be affected, and there can be swelling of the eye, proptosis of the eye, and orbital myositis causing diplopia and nerve compression and optic neuritis. And the orbit involvement is usually contiguous disease from nasal or paranasal sinuses. Microscopic polyangiitis, that is rarer than GPA, and usually presentation is at 50 to 60 years of age, and there's like male predominance, and they have constitutional symptoms at diagnosis. So like fever, weight loss, anorexia, these symptoms, and myalgia, and these patients also may present acutely or can have indolent course for few months. And RPGN is the major clinical feature of microscopic polyangiitis. And classic pulmonary finding is diffuse pulmonary hemorrhage presentation with dyspnea, short dyspnea, hemoptysis, fever, and anemia. And abdominal pain is the most common GI symptom. And there can be mononeuritis multiplex, which occur more frequently than CNS symptoms. So this is about a patient, 24-year-old man, who presented with numbness of hands and feet. And so within weeks, it progressed to weakness, particularly in hands, without weakness in feet. And found to have asymmetrical mononeuritis multiplex. He also had vasculitic rash over the ankles. And in addition, he had thrombosis of peripheral arteries, left dorsalis pedis and right anterior tibialis, which was shown in the arterial Doppler. So that is the other thing. So vasculitis patient, there's increased thrombotic tendency, and they can have thrombosis. In this patient, he had peripheral lower limb peripheral arterial thrombosis. His ESR was only little elevated, and CRP was high with neutrophilia, eosinophilia. eosinophil count was 7,400, and his ANCA were negative, and there was no renal impairment. And whenever there is a very high eosinophil count, so let's you have to consider with this picture, you have to consider the possibility of EGPA. And he was treated with rituximab 500 milligram weekly for pulses with complete resolution of all these symptoms. And so he was on anticoagulation also temporary because with vasculitis. So once vasculitis is controlled, no need to continue on long term. However, he also is a seaman, and so after the treatment he left, and after that still he didn't return back. So it's important to diagnose as ANCA-associated vasculitis, though these are rare disorders associated with increased morbidity and mortality. So you have to identify the life or organ-threatening manifestations, because these manifestations need treatment, aggressive treatment, in addition to IV glucocorticoids, treatment with either IV cyclophosphamide or rituximab. So these are the alveolar hemorrhage, glomerulonephritis, CNS vasculitis, mononeuritis multiplex, cardiac manifestations, mesenteric ischemia, and also digital ischemia. So what are the non-organ threatening manifestations? These are rhinosinusitis, asthma, mild inflammatory arthritis, mild systemic disease, and uncomplicated cutaneous disease. So in immune complex vasculitis, these are characterized by deposition of immunoglobulin or complements or both on the vessel wall. So these are predominantly small vessel vasculitis, and it's a heterogeneous group. And IgA vasculitis, cryoglobulin vasculitis, antiglomerular basement membrane disease, and hypocomplementary vasculitis also come under immune complex vasculitis. This is not uncommon, IgA vasculitis. This patient with IgA vasculitis, 24-year-old woman, presenting with vasculitic rash over both lower limbs bilaterally, and she also had crampy abdominal pain at the beginning without bleeding PR or bloody diarrhea. And she had ankle arthritis, and UFR, there was microscopic hematuria with subnephrotic range UPCR, and renal biopsy was done by renal nephroteam, and there were IgA deposits. So diagnosis is IgA vasculitis. So it's important to diagnose as diagnosis is important. So only by immunofluorescence can be diagnosed. And so IgA vasculitis treatment also depend on the manifestations. So if there is subnephrotic range proteinuria, so then these patients need at least 6 months of steroids. And if it is only microscopic hematuria, they may need only the follow-up. But if there's RPGA, need treatment as with cyclophosphamide, IV cyclophosphamide. But if there's significant sclerosis damage, then there is no indication for immunosuppression treatment. So it's the commonest vasculitis in children, and usually in children there's an association with upper respiratory tract infections like streptococcal infections, and in adults rarely there may be underlying malignancy, and it may present as single organ disease or systemic disease with multi-organ involvement. So if it is only skin, so we don't start with steroids. Steroids are not effective, and but for joints and GI involvement, steroids may be effective, may need on short term. So this is about a patient with cryoglobulin vasculitis. This is a 60-year-old female presenting with recurrent vascular rash for 2 years. So it's typically cryoglobulin vasculitis. They present with initial presentation is with vasculitic rashes, which may be going on for a few years. And she got admitted with history of fever few days, and she also had loss of weight for few months, and there was proteinuria, and nephrotic range proteinuria with normal serum creatinine and microscopic hematuria, and she developed bilateral foot drop after admission. with the nerve conduction study EMG showing mononeuritis multiplex, and she had very high ESR and CRP, and hemoglobin was low, and rheumatoid factor also was positive. So rheumatoid factor positivity, so it can be seen even in ANCA-associated vasculitis. So initially the patients may have treatment with these modifying drugs as for rheumatoid arthritis. But if there is rheumatoid factor is positive in high titers, always you have to think of cryoglobulinemia as well. So in these patients, however, cryoglobulins were negative, but serum complements were low. C4 was low with normal C3, and serum protein electrophoresis also showed monoclonal band with 0.9 grams per deciliter. And renal biopsy, there was acute diffuse proliferative glomerulonephritis, and it's reported as the cryoglobulinemia was so possible, and she responded to steroids. So initially we started treatment with cyclophosphamide, but with that she didn't respond. So after 3 pulses, we started her on rituximab. So her mononeuritis multiplex and proteinuria completely resolved within almost within few weeks, like within even 1 week. So the proteinuria disappeared, then mononeuritis multiplex also resolved. So if it is the diagnosis is cryoglobulinemia, so indication the rituximab is indicated. There is no evidence for cyclophosphamide, and always you have to exclude hepatitis B, C, and HIV infection. In this patient, these were negative. And even if it is hepatitis C associated cryoglobulinemia, rituximab is indicated. But if it is hepatitis B or HIV associated, then first we have to treat with antiviral treatment before starting rituximab. Anti-glomerular membrane disease. So these patients also there's like 2 peaks of presentation, can present with like 3rd decade or 7th decade. In younger patients, there's slight male preponderance, and their usual initial presentation is with acute renal injury, RPGN, but in 20 to 40% only renal manifestations occur, and pulmonary manifestations are due to pulmonary hemorrhage, and these may precede the renal involvement by months. And typically anti-glomerular basement membrane disease, they don't have systemic manifestations, but if there are manifestations like fever, arthralgia, fatigue, and these are rare, but usually these don't occur, but can occur rarely. But if these symptoms are there, always you have to do ANCA. Usually we do ANCA test if there is like pulmonary renal syndrome. So these systemic manifestations can occur if the ANCA is also positive. So that means double positivity. So then we have to treat as ANCA-associated vasculitis with longer term immunosuppression, because if it is anti-glomerular basement membrane disease, they need plasma exchange to remove the antibody as well, and they don't need longer term immunosuppression. But if double positivity with ANCA also positive, they need longer term treatment. So this is another patient. With this patient also was referred to us from nephrology, 61 years old female, and she had microscopic hematuria, and the renal biopsy, there was interstitial nephritis, and ANA also was positive. The patient was referred to us, and there was dry eyes, but there was no dry mouth there. And for about a few years, she was getting vasculitic rash and peripheral neuropathy of feet as well. She was not diabetic, and her ANA was positive, and anti-Rho and LA both were positive. And the cryoglomerular vasculitis also can result in vasculitic crash, but her cryoglobulin was negative. And the diagnosis was Sjogren's vasculitis, and she was, and in addition, she had this thin wall cyst in CT scan, so which can occur with Sjogren's vasculitis. However, she was asymptomatic pulmonary wise, and So the diagnosis is Sjogren's vasculitis. So these are the case reports that case histories that I wanted to discuss. And thank you for listening. Thank you.
Thank you, Monica. And before we start the question and answers, I would like to invite Dr. Buddhika Ilay Peruma, who has come all the way from Anuradhapura. He's consultant nephrologist at Teaching Hospital Anuradhapura. So after your lecture on kidney and vasculitis, we will have the question and answer session.
Right. Good afternoon, everybody, and thank you very much for the kind introduction. And I would like to thank two colleges, College of Rheumatologists as well as Sri Lanka Society of Nephrology, for giving me this opportunity to talk about vasculitis, which is related to the kidney. And so obviously I'm at a disadvantaged position as a fourth speaker. So it's so close to the lunch, and I know majority of my audience cardiac output is moving towards plasmic circulation than the brain. So, but I will try my best to make it interesting. Now we listen to 3 lectures. Basically, we are discussing on these rather uncommon. So disease entities, I can't say they are rare, but disease entities where the whole body is being attacked by the antibodies. One disease entity, SLE, so it's the DNA is the subject, and the other entity, the vessels, is the subject. So, but you have DNA everywhere in the body, so it will be attacked everywhere, and you have vessels everywhere in the body. So it's a generalized manifestation, right? So but the bad thing is the both diseases, the kidney is one of the common targets, and in both instances, the kidney would be one of the determinants of their basically the prognosis, the long-term as well as short-term prognosis. So that's why we wanted to do this as a combined lecture series to highlight the fact that the importance of kidney in these both entities. So my senior colleague, Dr. Monica, discussed about this bit. So we have, when it comes to, I'm basically talking about small vessel vasculitis, you know, there is medium size as well as large vessel vasculitides. They do have sometimes involved of the kidney, but the spectrum would be too large to me to discuss in a 30 minutes lecture. So I'm pertaining to small vessel vasculitis. So basically we have the ANCA associated vasculitis as well as the immune complex associated vasculitis. So in ANCA, you don't see this typical immune complex formation, and it's mainly the neutrophil induced damage. And in immune complex, yes, so the immune complex deposition, the typical complement activation, and so forth. So you have the IgA vasculitis, or the good old term HSC, and anti-GBM disease, a primary anemia, and hypocomplementary vasculitis in immune complex thing. And more familiar versions are in ANCA-associated vasculitis, where you have the GPA, MPA, and EGPA according to the newer terminology. So I would touch a little bit about the pathogenesis, because as I said earlier, in ANCA-associated vasculitis, it is mainly the neutrophils causing injury. So there was a debate about these ANCAs, the diagnostic antibody, whether they are really pathogenic, but there is enough or increasing evidence that ANCA themselves are pathogenic because they bind to the cell surface of the neutrophils and they activate the neutrophils, and which results in the vessel damage. And on the other hand, the place of the complement was rather disregarded at the early years, but there is again accumulating evidence of the complement activation in ANCA-associated vasculitis, and especially the alternative complement pathway, which might result in a more severe disease. And we do see people with ANCA-associated vasculitis with sometimes a low level of complement levels, which is not very common, but it could be there, and that might indicate more severe disease and with more severe organ involvement. But typically, the renal biopsy, you don't see the deposition of C3 or C4. So, so as I said earlier, kidney disease is quite common, and it's more common in GPA, the older weakeners, and the MPA, the microscopic polyangiitis. It's a little bit uncommon in EGPA, but it is one of the most important predictors of the mortality. And when it comes to this mortality, I mean, your creatinine need not to be high. Just mere involvement of the renal kidney, as shown in the renal biopsy, will decide on your prognosis. Your creatinine might be normal, but little bit of active sediments in the urine might indicate there is renal involvement, and we have to have a lower threshold for renal biopsy, especially when we are suspecting multisystemic involvement and people coming with a small vessel kind of skin vasculitis. I do have a lower threshold to biopsy them because sometimes the diagnosis is quite difficult, especially when the ANCA is negative. So the other highlight is the ANCA would be negative. And 90% of the GPAs, they might have ANCA positivity, but the MPAs and the GPAs, the ANCA positivity is 50% and even down to 30%. So the patient will come with a skin vasculitis, bit of arthritis, and you don't know what type of vasculitis is there and what is the true organ involvement. And if you do a skin biopsy, yes, you will see lymphocytoplastic vasculitis, and it's not going to add much beyond that. If you are fortunate, you will see IgA deposits in HSP, but it's just skin biopsy says it's vasculitis. But if you see a bit of urine sediments, so we go for kidney biopsy, and that would show the full-blown picture, the typical, post-immune type of glomerulonephritis in ANCA-associated vasculitis, and the immune complex type of glomerulonephritis in the other types of vasculitis. So they are very helpful in the diagnosis itself as well as determining your prognosis. So as I said earlier, so when it comes to these three types of ANCA-associated vasculitis, the GPA and MPA, they are kind of the renal involvement is quite common, as I said, and sometimes you might not be able to differentiate really between these two unless you have the PR3 ANCA positivity in GPA and the MPO ANCA positivity in the MPA. But the renal involvement is quite common as well as quite severe in GPA, and in MPA, yes, you can have the typical RPG kind of pattern, but there is a subset of people who have more indolent disease and more chronic kind of glomerulonephritis in MPAs. But EGPA, it's quite uncommon to them to have the typical RPG pattern, but they can have the chronic glomerulonephritis pattern. So when it comes to kidney biopsy, there are a few salient things. So the necrotizing glomerulonephritis. So the necrotizing is you will see the necrosis of the glomerulus and the leaking out of contents. So that is a more typical pattern of glomerulonephritis we see in these vasculitides, the ANCA-associated vasculitides. Presence of crescents, yes. So you might see crescentic glomerulonephritis commonly. So the number of crescents might not, give the true nature of the disease, because originally we say it is as a crescentic glomerulonephritis, you have to have more than 25% of the glomeruli having crescents, but this could be very patchy. So even presence of a single crescent will say that your disease is quite severe. So and there are patients have encountered where you don't see crescents, but they behave like a crescentic glomerulonephritis because their creatinine is rising rapidly. That is because your biopsy might have missed the crescent. So, but whatever it is, the renal involvement of the ANCA-associated vasculitis is mostly quite severe, and you have to have a low threshold to escalate your immune suppression. We'll talk about the management a bit later, but keep that thing in the mind because the renal involvement in ANCA-associated vasculitis is a true nephrological emergency because you have to treat them early with aggressive immunosuppression. And if you have a backward stance, sometimes it might result in a more advanced renal damage and causing death and dialysis dependence in the future. So in EGPA, you will see the eosinophil-rich inflammation with granulomas, and in GPA also you will see granulomas. And the rarer manifestation is the interstitial nephritis. Just keep it in the mind, because sometimes you might not see the glomerular lesions, and it would be just an interstitial inflammatory response. And but that is one of the presentations. So it's important to keep that thing in the mind because interstitial nephritis is a quite common entity in Sri Lanka and rather undiagnosed. And also the part of the country I'm coming from, the Anuradhapura, where the interstitial nephritis itself is a very common entity because of the agriculture-associated kidney disease, where you will see interstitial infiltrating most of the kidney biopsies. So sometimes it's harder to differentiate these vasculitides when they're present with the interstitial inflammation. So you have to have a high threshold of kind of a lower threshold of suspicion. So so what are the principles of management? So that those are the main things I'm going to discuss. So how do we manage? So now my previous colleague, Dr. Amal, discussed about the SLE, where when we compare to the other diseases, it's at the tortoise speed. The evidence accumulation is at the tortoise speed. So I was just wondering, where should I place ANCA-associated vasculitis when it comes to the evidence? Probably the snail, I would say, because it's much scarce. The evidence and the guidelines is much scarce compared to the SLE. So that's why I'm telling the clinician has to be quite smart, and you have to have a lot of experience to deal with ANCA-associated vasculitis because it's quite severe, and you have sometimes your time interval for the decision making might be quite less, especially somebody coming with rapidly worsening glomerulonephritis as well as a pulmonary neurologist. So you need to have a lot of understanding, and and unfortunately, most of the cases of ANCA-associated vasculitis with organ-threatening disease is being undertreated and leading to death and end-stage kidney disease. So that's why I call it as a real nephrological and rheumatological emergency. So moving on to the principles, as I said, sometimes when the severity is quite high, you have to hit hard early. So that is one of the principles in a developing stage. How do we do this induction treatment, which I will discuss in my next few slides. What are the determinants of the induction treatment? Is it just methylprednisolone, or do we need to combine methylprednisolone with cyclophosphamide, or do we need to combine methylprednisolone, cyclophosphamide plus rituximab? So that's the kind of evidence and the patterns moving in the current era of management of these vasculitides. And so there are a few things. So the remission of the kidney disease, so you start the treatment according to the creatinine and the presence of active sediments, and you do a biopsy, you diagnose the renal involvement, you start the treatment, and how do we know whether the kidney has achieved this remission? So it's mostly the stabilization of creatinine and the disappearance of active sediments, the red cells, the microscopic hematuria disappearance are the two main important indicators of the stabilization and the remission. The proteinuria, in contrary, might not really show the real stabilization. Sometimes you might see people who creatinine has stabilized and your active sediments have disappeared, but they are still proteinuria. But that does not really say that disease is active, because the proteinuria in most of the cases it's really due to the renal damage rather than the activity of the disease. So so you can't just go by the proteinuria. So just mere the presence of proteinuria, that might not be an indication to keep on hitting, and that is just the tubular proteinuria getting from the damaged tubules. So that's something to keep it in your mind. And the value of anchor monitoring, because sometimes it's quite difficult because we don't have a real monitoring thing in ANCA-associated vasculitis. Maybe disappearance or stabilization of the symptoms. When it comes to the kidney, it's just the sediment and the creatinine. But sometimes people tend to monitor the ANCA levels. So there is mixed evidence, but most of the centers, they really don't treat when they see the ANCA level escalation, because sometimes even though ANCA antibody titers starts rising, it does not really overlap with the clinical feature manifestations. So you have to keep on monitoring them closely, and if you can do ANCA monitoring, that's good. But just mere presence of ANCA rising is not an indication to escalate your immunosuppression. So, so what are the options we have? So the glucocorticoids is one of the central components of the treatment. But unfortunately, just glucocorticoids is not at all sufficient themselves to treat the renal involvement of ANCA-associated vasculitis. That's why we have the other options as cyclophosphamide and rituximab coming into the play. So in a patient, in a typical patient with a RPGN picture or the alveolar hemorrhage with ANCA-associated vasculitis, we start steroid induction with methylprednisolone, and we discussed about this in the previous two lectures, the dosing of methylprednisolone. So when it comes to, because nowadays both the rheumatology and nephrology is moving away from steroids. That's the kind of general principle, because the toxicity of steroids, there is increasing evidence of the toxicity of steroids is doing more harm than good in overall all the nephrological and I'm pretty sure in the rheumatological aspect as well. So we are trying to move away from steroids, and we are trying to reduce the steroid exposure as much as possible. So in methylprednisolone dosing, as I said earlier, so we can try 500 milligram instead of 1 gram, but the response, the practices in ANCA-associated vasculitis is a little bit different to SLE. So people sometimes give 1 gram methylprednisolone depending on the overall severity as well as the weight. So you can try methylprednisolone at the beginning, 3 doses daily, and then moving on to oral prednisone. So most of the time, still it is a 1 milligram per kilogram oral prednisolone, but with the help of the other immunosuppressants, which I will discuss in the next few slides, we try to minimize the duration of 1 milligram. So try to give it like 2 to 4 weeks, and then to start tapering it early and continue it for about 6 months before starting on the proper maintenance treatment. So what is the place of cyclophosphamide and rituximab? And there are a few studies comparing cyclophosphamide versus rituximab as the induction agent of ANCA-associated vasculitis. As I said earlier, the methylprednisolone is not itself is enough. So we need to combine NPP with either of them, either cyclophosphamide or rituximab. So these two studies, the RAVE and the RituxVASC studies, confirmed that rituximab is non-inferior to cyclophosphamide in achieving remission. So as the induction treatment. So the current trend of the ANCA-associated vasculitis is will be moving away from cyclophosphamide and going towards rituximab as both in induction as well as I will discuss later about the maintenance with rituximab as well. So the rituximab dosing, again, we are at the very beginning of the studies. Still, the dosing regime has not been finalized. Various doses have been tried, and these two studies, the path-breaking studies, the railway rituximab, they tried a quite higher dose of rituximab, which were given weekly, 4 weeks as the induction. But there are studies which tried the two-dose regimes, like two doses in a gap of 2 weeks, 500 milligram as well as 1 gram. So there are studies which shows benefits, but still the evidence is quite mixed. So, but keep in mind, rituximab is a very good option for cyclophosphamide when it comes to the induction. So what about cyclophosphamide? So again, the dosing depends on the center. There are a lot of differences between centers, but the older Cyclops trial, they gave a bit of a higher dose of cyclophosphamide, 15 milligram per kilogram. This would translate into something around 1 gram in a 60 kilo person. So we give 3 doses 2 weekly, and then you give another 3 to 6 doses 3 weekly. So that was the older regime. But there are studies which has given all 6 doses, like in lupus patients, 2 weekly 6 doses. And but unfortunately, we don't have much evidence to compare between these various cyclophosphamide regimes. But just keep it in mind, that is one of the induction agent we use. When it comes to the dosing, so in patients with severe renal impairment, we tend to decrease the dose. For example, people with RPGM with a very low, very high creatinine level, when the eGFR is 30, can halve the dose of cyclophosphamide you give, and especially in the elderly people, you give a lesser dose of cyclophosphamide when it comes to renal involvement of ANCA-associated vasculitis. Is there a place of MMF? Yes, especially those who have a milder involvement of the kidney, where you don't have like a typical RPGM picture. It's just the glomerulonephritis, only the stable serum creatinine, and then you can try MMF. But the evidence for MMF is showing that this can cause higher rate of relapses. So that's why the rituximab and cyclophosphamide is more preferred. But in people with MPA, where the renal involvement might be less severe than the GPA, and GPA is more kind of a relapsing disease than MPA. So where we would prefer rituximab or cyclophosphamide in GPA, but yes, you can consider MMF as the induction agent in MPA with a less severe renal involvement. So, so next big argument we had over the years was, are we subjecting them for plasma exchange or not? So we had a couple of studies. The Pexidas out of that is the more comprehensive study, which about like 700 ANCA-associated vasculitis people to check the role of plasma exchange. So the results of Pexidas was a little bit discouraging towards plasma exchange, because the Pexidas involved people with significant renal involvement. Their baseline eGFR was less than 50, and there were people with diffuse pulmonary hemorrhage as well. The outcome with regard to the death as well as end-stage kidney disease at 1 year, as well as after 7 years of follow-up, the outcome was not promising, and it does not subjecting these people to plasma exchange does not result in a major difference of death or end-stage kidney disease. So because the initial practice was with regard to the ANCA-associated vasculitis and renal involvement, whenever they have a severe renal involvement, perhaps sometimes they have a cutoff of serum creatinine above 4, and if they are presenting with dialysis dependency at the very beginning, so we subject them for plasma exchange at the very beginning, and also when they are presenting with pulmonary hemorrhage, we subject them for plasma exchange. But the evidence is a little discouraging nowadays. So some of the major centers in Europe as well as US, they have moved away from plasma exchange. But when it comes to Sri Lankan context, one thing I need to highlight, because the people comes to us with kind of a pulmonary renal syndrome, and so pulmonary renal syndrome has other differential diagnosis as anti-GBM disease as well. So anti-GBM disease, yes, the plasma exchange is still indicated because we don't have any studies disapproving plasma exchange. So in our context, we don't get these ANCA studies timely. Sometimes it might take 2 or 3 weeks. Patient might come with typical RPG and pulmonary hemorrhages, and we don't know whether they are GBM or whether they are ANCA or whether they are something else. So at the beginning, we don't have an option to start plasma exchange plus aggressive immunosuppression treatment, and then once we get the definitive investigation and the full understanding about the picture, yes, we might consider stopping plasma exchange if it is the typical and associated vasculitis. So, but still, there are some European centers, they do practice plasma exchange in very severe pulmonary hemorrhages, because one aspect in Pexila's study was the amount of people with a severe pulmonary hemorrhage was quite less in that study. It's more kind of very mild to moderate pulmonary hemorrhage. So that's why some centers, people with severe pulmonary hemorrhages requiring intubation and ventilation at the beginning, they still proceed with plasma exchange. But when it comes to the renal involvement, yes, it's quite unsure whether to do or whether not to do. But instead of proceeding with plasma exchange, hitting hard with the immunosuppression would be the way forward when it comes to renal disease, according to the current level of evidence. So, so what are the novel approaches with regard to the remission induction therapy? So as I highlighted earlier, this the combination of rituximab and cyclophosphamide is coming as an emerging treatment in some of the major centers when it comes to the renal involvement of the ANCA-associated vasculitis, because it allows us to ask for a more rapid glucocorticoid taper, and also the initial management with this combination might result in a more sustained remission, and the chances of relapses are going to be quite less. But the real randomized trial evidence is still quite less. But there are instances we can consider the combination of rituximab and cyclophosphamide, especially somebody who has a relapsing disease. So whenever a patient present who had a disease prior to the current presentation, they had the RPG in picture, and then now coming in the relapsing disease with RPG in picture, yeah. So that is there one indication to try the combination. But because we tend to try, so if they were treated initially with rituximab, then we try to consider cyclophosphamide in the second instance, the vice versa. But sometimes when the disease is severe, yes, you can try the combination, and this is being practiced in some of the vasculitis centers in the other countries. And this novel treatment, now I discussed about the complement activation earlier. It can be seen in severe disease. So the new kid in the block is called a complement receptor inhibitor called avacopan, which is kind of slowly coming into the practice in the European countries, where avacopan is considered one of the induction agent which help us to taper the steroids quite rapidly. So this might appear in the guidelines sooner. So, so all this time we discuss about the induction. So we need to decide what to do after the induction, after achieving the remission, what is the preferred maintenance regime. So for years, the azathioprine has been the gold standard for the people with renal involvement and associated vasculitis. But there were few studies, the Melrixan 1, 2, and the rituximab. They compared the rituximab as a maintenance agent compared to azathioprine, and there were quite promising results where the two of the studies showed the superiority of the rituximab over azathioprine as the maintenance treatment. So, I mean, most of the vasculitis centers in other countries have moved away from azathioprine as their maintenance agent, because the rituximab regimes are quite easier, because we give rituximab like sometimes 4-monthly or 6-monthly intervals up to 2 years as the maintenance treatment. So you achieve the remission, and then you try to reduce your steroids as much as possible, and you need to give only rituximab as the maintenance regime, and that also like 4 monthly intervals. And you need not to give azathioprine as a long-standing drug. So these regimes have been quite popular, and in fact has resulted in good results. So but there are instances you still prefer azathioprine, where if you have having like a childbearing plans and so on and so forth, because rituximab has not really characterized in people with planning for child the pregnancy. So but the rituximab is the way forward when it comes to ANCA-associated vasculitis renal involvement. So azathioprine, as I said, it's still we are practicing azathioprine. The better to start a lower dose where the TPMT levels are not available, otherwise you will result in quite bad pancytopenias. So, but if the TPMT levels are normal, you can start usually at a dose of 2 milligram per kilogram per day as the maintenance. So duration of maintenance, again, nobody really knows. But most of the patients, we try to limit it to 2 years, where the clinical picture is less severe and the remission is achieved quite early. But there are few instances we tend to continue the maintenance treatment quite longer. One is the PR3 ANCA positivity in GPA itself shows the chances of higher relapses, and also lung involvement and also upper respiratory tract involvement sometimes predicts higher relapsing rate. So we might continue it for a longer duration. And what happens if one gets a relapse? So then, and with the relapse of renal involvement, and sometimes we might have to continue indefinitely the maintenance regime. So what is the place of rituximab and those kind of instances, still we don't know. And one observation we have seen is people who are progressive to stage kidney disease, they usually have an overall lesser number of relapsing rate because they go into kind of quiescence of their immune damage. And this is one of the study I had the opportunity to participate during my O6 training at Aberdeen, where it was a referral center for vasculitis, and I could present this in the Scottish Renal Association annual sessions, where we compared, because the rituximab dosing was not really studied, and there are studies where explore the rituximab dose as an induction agent, but there are some other studies where explore the rituximab as the maintenance agent. But as I said, now we are moving towards rituximab as an induction plus maintenance. There are no studies to compare that, as well as the difference between various doses. So in this study, that was an observational study where we compared people who received rituximab as an induction as well as maintenance, and different dosing regimes. One set received 500 milligram, the lower dose, and one set received 1 gram as a higher dose. But the interesting observation was the long term, after 2-year follow-up, the renal remission as well as the dialysis requirements, the things are quite similar between the 2 doses. And so, but we need a bigger study and more kind of randomized study to compare these dosing regimes to arrive at a final conclusion about the dosing. So that was all about the ANCA-associated vasculitis. I will just briefly touch the other vasculitis, especially with regard to the management. And so cryoglobulinemia is the other type of small vessel vasculitis, the renal involvement we see. But it's cryoglobulinemia mostly you will see, which is sometimes secondary to some other disease. So managing the primary disease will highlight the management of the cryoglobulinemia. And also, when it comes to cryoglobulinemia, you can have mild disease, moderate or severe disease. So moderate or severe disease will be diagnosed with severe organ involvement, the renal, the digital ischemias, and the GI and the CNS involvement, as well as the lung involvement confers the moderate to severe disease. And so I think my previous colleague, Dr. Monica, discussed about this thing about the HCV associated cryoglobulinemia, how to manage. So if the disease manifestations are quite severe, So we do start treatment with immunosuppressive therapy early, and then try to stabilize the disease, and then start the HCV treatment sometimes later on, because but we can do this thing commonly with immunosuppression methods with rituximab than cyclophosphamide, because sometimes when we give cyclophosphamide for the people with HCV or HPV, the chances of infection recurrence might be a bit higher than the rituximab. So there are regimes of combination of glucocorticoids plus rituximab for people with HCV plus severe renal involvement to try beginning than steroid plus cyclophosphamide. So what's the place for plasma exchange in these people? Yes, there are mixed evidence, but people with RPGM requiring dialysis and refractory organ involvement, and sometimes people with symptomatic hyperexcessive syndrome, we do proceed with plasma exchange. So that was a brief discussion about cryoglobulinemia. When it comes to IgA vasculitis, the hematochondrial so the difference between HSP and the other vascularities affecting the renal, the kidney, is usually most of the instances, the IgA vasculitis with renal involvement is less severe than the other types of diseases we discussed so far. And if the proteinuria is less than 0.5 grams, and if it is just the mere presence of active sediment, sometimes the treatment of the, usually if the skin rash is quite severe, the rheumatologist will start steroids, and that itself is more than enough for the renal remission in most of the instances. But sometimes there are uncommon instances we might have to give IV methylprednisolone, where you will see the typical RPG kind of picture. And the renal biopsy indications, yes, so if the proteinuria is less than 0.5 grams, and just the activity of the urine, and if your creatinine is normal, and if your picture is typical, and it's a small child coming with a typical picture of IgA vasculitis, yes, then you might not go ahead with the renal biopsy there, because the diagnosis is straightforward. But as I told earlier, if the proteinuria is severe, the creatinine is rising, it's worthwhile to proceed with the biopsy, and mostly not for the treatment purposes, but for the prognostication purposes, to see what's the kind of renal damage these patients are having. And there are instances we might have use even cyclophosphamide and rituximab in more refractory cases. So that brings to the conclusion of my presentation. So basically the message is, so the vasculitis with renal involvement, sometimes it might be difficult to diagnose, and your antibodies, the classic antibodies, your ANCAs, might not be there to support the diagnosis. So you can get the support from the renal department for the renal biopsy to characterize the disease, as well as to decide on the further management, as well as the prognostication of the disease. Thank you very much.
Thank you very much. Any questions from the audience? Very little audience left. Any questions from the audience?
I have one question from Buddhika. After the MEPEX study, what is the stand now? MEPEX was more in favor of plasma exchange in antivasculitis in severe kidney disease where the creatinine is more than 400.
So basically, the two studies showed different outcomes. So I think at least one study has shown major benefits with people with renal involvement. That might be one reason still some are practicing plasma exchange as the first line treatment for people with significant renal involvement. So, but the center I worked, especially despite after the MEPEX and the studies, they still did not really proceed with the plasma exchange.
So because I think probably something to do with the population involved as well as the pros and cons of both studies. But I think from for our purposes, as I told earlier, still there is place for presentation.
I think basically only with pulmonary hemorrhage we should exchange. Otherwise, we'll be careful on your decision making.
There's another analysis after same study. After 1 year, the end-stage kidney disease is less if after plasma exchange. So now there's also is high, or there's hypoxemia with pulmonary hemorrhage. They say that now it's indicated. I think some centers they recommend that. So if the kidney is high, more than 5.2 or something, and if there's hypoxemia with pulmonary hemorrhage, so plasma exchange now they go for that according to rheumatology data.
Yeah, so with the pulmonary hemorrhage and hypoxemia, yes. So without pulmonary hemorrhage, yes, still it's still divided. There's no universal acceptance. Yes.
The opinion is still divided, but I think one good indicator would be the renal biopsy findings at the beginning. What's the amount of chronic damage shown in the biopsy, the interstitial fibrosis and the tubular atrophy? If it is quite high, if thing has been going on for a while, and then the amount of glomerular necrosis shown, if the chronic damage is quite high, sometimes people don't do plasma exchange for them. But if the still is kidney is pristine and it's only the acute proliferation is going on, that might be one indication to consider plasma exchange.
Thank you. Can we call all the 4 speakers to get their token of appreciation?
Dr. Amal Tirakaratna, consultant rheumatologist at District General Hospital, Matale. Dr. Dilrushi Pilapitiya, consultant nephrologist at Sri Javadana General Hospital. Dr. Monica De Silva, consultant rheumatologist at National Hospital of Sri Lanka.
And Dr. Buddhika Ilayapurama from Teaching Hospital, Anuradhapura. With this, we conclude the session. Thank you for persisting with us until the late lunch hours.